السلام عليكم أعزائي طلاب المرحلة الخامسة كلية الطب جامعة واسط. معكم الدكتورة اريج صباح. عنوان محاضرتنا Urinary Tract Disorder in a Pregnancy. Physiological and anatomical changes during a pregnancy. Number 1. The length of the kidney increased by about 1 to 1.5 cm and the renal calyces and the pelvis are dilated. Number 2. The ureters are dilated above the brim of the bony pelvis with the more prominent effect on the right, which predisposes to ascending urinary infection. Several factors likely contribute to hydronephrosis and hydroureter in pregnancy due to presence of placental hormone, which is mostly progesterone, which causes hypotonia and urethral smooth muscle relaxation, and also hyperplasia of the smooth muscle in the distal 1/3 of the ureter, and this will lead to reduction in the luminal size and leading to dilation in the upper 2/3 of the ureter. Also, presence of sigmoid colon and the dextrorotation of the gravid uterus reduce compression and dilation of the left ureter relative to the right one. Also, number 3 of physiological changes in a pregnancy related to urinary system, we have increase in the glomerular filtration rate with saturation of tubular resorption capacity for filtered glucose. This will lead to glucosuria. 50% of women with glucosuria sometimes during a pregnancy, and this will lead to increased susceptibility of pregnant women to urinary tract infection. يعني because of increase in glomerular filtration rate مثل ما أخذتوا بالphysiology of pregnancy, this will lead to increase or result in glucosuria, and about 50% of women, pregnant women, develop glucosuria, and this may contribute to development of urinary tract infection. نيجي الموضوع مهم جدا اللي هو asymptomatic bacteriuria. It is very important in obstetric. Definition of asymptomatic bacteriuria is the presence of actively multiplying bacteria in the urinary tract. طبعا excluding the distal urethra اللي هو ممكن إنه نلقى به multiplying bacteria. عايش وقت in patient without any obvious symptoms of infection of urinary tract infection. يعني patient has no symptoms لكن راح نشوف actively multiplying bacteria in the urinary tract. The incidence is 2 to 10% in all pregnant women. Risk factors for asymptomatic bacteriuria: low socioeconomic status, primary parity, age. كل ما البيشنت كانت younger كل ما more susceptible for asymptomatic bacteriuria. Medical condition as diabetic and sickle cell trait. Those patients with these medical disorder are more liable for asymptomatic bacteriuria. Pathogenesis of asymptomatic bacteriuria. Approximately 90% of those patients infected with E. coli and other microorganisms as Klebsiella enterobacter, Serratia group, Staphylococcus aureus, Enterococcus, and group Beta Streptococcus and Proteus are responsible for the remainder of. Diagnosis of asymptomatic bacteriuria. The diagnosis is based on isolation of microorganisms with a colony count of 100,000 of organism per milliliter of urine in a clean couch specimen in women who is experiencing no symptoms of urinary tract infection. Complications of asymptomatic bacteriuria. The main risk of asymptomatic bacteriuria is the development of pyelonephritis. So, this is the cause why the asymptomatic bacteriuria is an important object in obstetric, because it is asymptomatic and carry high risk of complication as a pyelonephritis, and its complication mean the pyelonephritis complications. If asymptomatic bacteriuria is left untreated, so 40% of women will develop symptoms of urinary tract infection. And approximately 25 to 30% of those women will develop acute pyelonephritis. With the treatment, this risk will decrease to less than 10%. Asymptomatic bacteriuria has been also associated with preterm delivery and fetal loss. So the treatment of asymptomatic bacteriuria associated with reduction in the risk of preterm birth and low birth weight babies. For prevention of asymptomatic bacteriuria is done by monthly routine urine culture performed in those patients with high risk of asymptomatic bacteriuria. Treatment of asymptomatic bacteria means after diagnosis of asymptomatic bacteriuria, the treatment bacteriuria respond to empirical treatment with several antimicrobial regime. We have single dose treatment or single dose regime as amoxicillin of 3 gram, ampicillin 2 gram, cephalosporin 2 gram, nitrofurantoin 200 mg, and trimethoprim sulfamethoxazole 320 per 1600 mg. This is a single dose regime or single dose treatment for asymptomatic bacteriuria. We have also a 3 days course of treatment of asymptomatic bacteriuria. Also, we have amoxicillin about 500 mg 3 times per day, ampicillin 250 mg 4 times per day. Also, cephalosporin and ciprofloxacin, levofloxacin, nitrofurantoin, and also we have trimethoprim and sulfamethoxazole. This is known as a 3 days regime or 3 days course of antimicrobial for treatment of asymptomatic bacteriuria. So the treatment is use only one of these drugs, not all drugs in the regime. Acute cystitis. In acute cystitis is uncommon in pregnancy and it's about 1%, and the bacteria causing acute cystitis are similar to those in asymptomatic bacteria. Regarding the clinical finding in acute cystitis, clinically the patient present with symptoms of urinary frequency, urgency, dysuria, and suprapubic discomfort, and the urine often is cloudy and malodorous. That means when the patient is symptomatic, so only we need the presence of a colony count of more than 1,000, while in asymptomatic bacteriuria, we want a colony of 100,000 because she is asymptomatic, but here she is symptomatic of urinary tract infection. Treatment of acute cystitis. Most of the 3-day regime are usually 90% effective in treatment. In case of lower urinary tract symptoms with pyuria, accompanied by sterile urine culture, that means when the patient presented with symptomatic infection, urinary tract infection, and when we do a urine culture and was sterile, so this is maybe due to presence of urethritis caused by chlamydia trachomatis. Mucopurulent cervicitis usually coexist in this condition, so azithromycin therapy is effective in this condition. Acute pyelonephritis. It's about 1 to 10% of all pregnant women. Renal infection is the most common serious medical complication of pregnancy. Develop more frequently in second trimester, nulliparous, and young age. Those are more susceptible for acute pyelonephritis. It is unilateral and right-sided in more than half of the cases. يعني half of the cases are unilateral right-sided and bilateral in a fourth of cases. Clinical finding. In acute pyelonephritis is usually abrupt onset with fever, shaking, chills. Number 2, aching pain in one or both lumbar regions. Number 3, anorexia, nausea, and vomiting may worsen dehydration. Also, their tenderness usually can be elicited by percussion in one or both costovertebral angles. Diagnosis. How we can diagnose acute pyelonephritis? By urine examination will reveal significant bacteriuria with pyuria and white B cells cast in the urinary sediment. Urine specimens should be obtained and sent for culture before any antibiotic are given. Why? In order to properly identify the causative microorganism and antibiotic susceptibility. Also, blood culture may be sent as they will be positive in about 10 to 20% of the infected women. Complications of acute pyelonephritis. Number 1, bacteremia, and it's about 15 to 20%. E. coli are 70 to 80% of infections, and also Klebsiella pneumonia and Enterobacter or Proteus species, and also there is a gram-positive organism include group beta, Streptococcus and Staph aureus. But the most common microorganism is E. coli. Number 2, sepsis syndrome, which is common in pregnant women with acute pyelonephritis. 20% of pregnant women develop renal dysfunction. Endotoxin-induced alveolar injury. This injury leads to an increasing of alveolar permeability and then leading to various degree of respiratory insufficiency as pulmonary edema, acute respiratory distress syndrome. While endotoxin-induced hemolysis is common, and about one third of patients with pyelonephritis develop anemia due to hemolysis. Obstetrical complications as preterm labor, prematurity, fetal death, and intrauterine growth restriction also may be occur in women with acute pyelonephritis. Uterine activity from endotoxin is common and related to fever severity. Tocolytics here should be used with extreme caution. Why? Because they can greatly increase the risk of respiratory distress syndrome in those women who have acute pyelonephritis. Management of acute pyelonephritis. Number 1, hospitalization. Obtain urine and blood culture and evaluate hemogram, serum, creatinine, and electrolytes. Also, monitoring of vital signs frequently as urinary output, and also put or consider indwelling catheter to assess the urine output. Intravenous crystallized solution. Also administer intravenous antimicrobial therapy by first generation of cephalosporin, which is category B, acefalozolime 1 gram parenterally every 8 hours, and ceftriaxone also 1 gram parenterally every 24 hours often is effective for most Enterobacter. Urine culture and sensitivities guide therapy thereafter. When patients become afebrile for 48 hours, parenteral therapy may be changed to ineffective oral antibiotics, and the total course of antibiotics is 14 days. Chest radiograph. We may need it if there is a dyspnea or tachypnea. Also, repeat urine culture 1 to 2 weeks after antimicrobial therapy completed, to be sure that the patient is relieved from the infection. In case of persistent infection, when there is no clinical response seen in 48 to 72 hours, so there may be a resistant organism presence, and they may be treated by adding an aminoglycoside as gentamicin 3 to 5 mg per kg per 24 hours in 3 divided doses, and they are given every 8 hours. Failure to respond may cause by urolithiasis or structural urinary tract abnormalities, so ultrasound imaging for kidney and urinary tracts usually is the next diagnostic test. In case of presence of perinephric abscess that cause persistent pain and fever, this can be also identified by ultrasound. Perinephric abscess is due to obstruction complicated by infection. Perinephric abscess should be drained percutaneously in addition to administration of antibiotic therapy. سنجي على موضوع مهم آخر اللي هو abdominal pain in pregnancy. Abdominal pain in pregnancy ممكن divided into pregnancy related condition and pregnancy related condition also depending on gestational age divided into two groups. Early pregnancy abdominal pain less than 24 weeks and later pregnancy more abdominal pain more than 24 weeks. In early pregnancy, the abdominal pain may be due to ligament stretching, miscarriage, ectopic pregnancy, acute urinary retention due to retroverted gravid uterus. While in cases of later pregnancy, more than 24 weeks gestation, abdominal pain may be due to labor, placental abruption, HELLP syndrome, uterine rupture, and chorioamnionitis. The other category of pregnancy abdominal pain is pregnancy unrelated condition, and also they are classified into uterine or ovarian causes, which include torsion or degeneration of fibroid and ovarian cyst accident. Urinary tract infection, urinary tract disorder also. There is a urinary tract infection as acute cystitis, pyelonephritis, and renal colic. Also, there is GIT disorders as gastric or duodenal ulcer, acute appendicitis, acute pancreatitis, acute gastroenteritis, intestinal obstruction or perforation. Other causes unrelated to pregnancy are medical causes as sickle cell disease due to abdominal crisis lead to abdominal pain, diabetes, ketoacidosis, acute intermittent porphyria, pneumonia, and especially when it is lower lobe pneumonia, and also pulmonary embolism and malaria. Thank you very much.